So this is to finish up on the urinary system. So after the urine is basically made in the nephron, collected up in the minor calyx, goes to the major calyx, goes to the pelvis of the kidney, then it goes down the ureters. So we'll start with talking about urine itself. It's, you know what it looks like. It tends to be a little bit yellow. The more concentrated it is, the darker it is. So it can be very clear, or it can go all the way to yellow, depending on how much water that you reabsorb. Various things can alter the color, beets, that kind of thing. It can alter the smell of it as well. Most of the time, it is not, there shouldn't be any smell until it's been standing around for a long time. So it develops an ammonia smell because the urea degrades into ammonia when it sits for a while. It's slightly acidic. It's interesting. It's usually a pH of about 6. I like this, the range 4.5 to 8, which makes it pretty on the alkaline side. You want it to be slightly acidic because acidic urine is not hospitable to bacteria. So it prevents, by being acidic, it prevents bacterial infections. It is slightly more dense than water, but not much. It is mostly water with stuff dissolved in it. Like I say, 95% is water. What you really want dissolved in it is nitrogenous waste, so urea, uric acid, and something called creatinine. You want to actually be removing the creatinine from your body. Yeah, that's what mostly what you want to have go. Excess sodium, potassium, phosphates, calcium, magnesium, bicarbonate is usually in there as well, because normally we take in more than we need of these things. And urinalysis really looks at the solutes and tries to figure out what's normal, because different pathologies will change the constituents. So urinalysis is an important diagnostic tool. Okay, so the urine is conveyed to the bladder from the kidneys by 2 tubes called the ureters, one for each kidney. Now these tubes are found on the back wall of the abdominal cavity, and they're retroperitoneal, like they're behind the peritoneum. So one side has a serosa and the other side has an adventitia. And so they pass down behind the bladder, and they enter the bladder on the underside posterior. And the reason that it does that is because there's really no valve on the ureters. They enter the bladder on that angle, and as the bladder fills, the bladder puts pressure on the ureter and basically closes it off. And as you're urinating, the pressure that you put in the bladder to urinate with the detrusor muscle actually presses against the ureters and closes them off, just squeezes them closed, and prevents backflow of urine up into the kidneys. So, like a lot of tubes in the body, there's 3 walls of the ureter. There is an epithelium, and it's a transitional epithelium. It is an epithelium that changes along the course of it. There is a muscularis, and it's made of smooth muscle, it contracts in response to stretch, so it's really designed for peristalsis, because the way that urine moves to the bladder is by peristalsis. And then there's this outer adventitia with a little bit of serosa on the abdominal cavity side. So when you look at it, in cross-section, it looks like this, with a fairly highly developed longitudinal and circular layer of smooth muscle. Not very much different than, say, an artery. The epithelium is different, but it is the same sort of structure. We're not going to talk about kidney stones. You'll talk about those in pathology. So the ureters basically are these tubes, these muscular tubes that with peristalsis move urine towards the bladder. And the bladder is basically a storage place. It's just a sac for storing urine. It's, again, retroperitoneal. It's on the pelvic floor. And the walls are made of muscle because that helps with urination. But basically, the bladder is just there to store urine until it's convenient to urinate, to pass the urine. It's found anterior and below the uterus in women, and it's anterior to the vagina. And in men, the prostate gland is found basically surrounding the neck of of where the urethra exits the bladder. But other than that, it's pretty much very few features. The one feature that matters is this area called the trigone. And it's a triangular area on the floor of the bladder, and it's got the openings for the two ureters and the opening for the urethra in the trigone. And it's attached. It doesn't move because this is where the tubes are. So because it doesn't move, and this is where you tend to get bladder infections, is in this trigone area. The walls of it have got smooth muscle, and it's a lot like the stomach in that there's three layers. There's an oblique layer as well, and we call this muscle the detrusor muscle. There's an adventitia and a serosa on the superior surface, and inside the mucosa is an epithelium. It's a transitional epithelium, very much the same as what's lining the ureters. It's got these folds in it called rugae, and basically what they are is designed so that the bladder, as it fills, the rugae disappear because the folds allows it to expand, kind of like an accordion. So when it expands, it rises superiorly into the abdominal cavity. And because it gets bigger quite readily, pressure doesn't increase in it. It's not really subject to Boyle's law, because as volume increases with the contents, pressure stays the same. So it looks like this. So the rugae are these folds here that allow the expansion of it. The detrusor muscle is all around, right? The ureters come down and enter in the posterior part of the trigone. In the anterior corner of the trigone, it's the urethral opening. Now, the urethral opening has got a muscle that surrounds it called the urethral sphincter. Okay. Now there's a couple of muscles up here, right at the bladder end of the urethra. There is a smooth muscle sphincter, that's the internal sphincter, and it normally keeps the bladder closed. When there's the urge to urinate, that will relax, and then you use this sphincter here that's in the pelvic floor. It's called the urogenital diaphragm, that's made out of skeletal muscle, and that skeletal muscle then you contract voluntarily and you keep it closed until it's time to urinate, until it's time to pee. This muscle, the external sphincter, is what you can use to stop the flow, even mid-flow. You just contract it. That's really about the only thing that's interesting about the bladder. So from here up, it's in the cavity. From here down, it's buried in tissue. And the urethra leaves from that anterior corner. The internal urethral orifice with the internal urethral sphincter. The urethra, again, is a muscular tube. And it's got a pseudostratified columnar epithelium. It goes from transitional near the bladder, and near the opening, near the external orifice, by that point it's stratified squamous epithelium. This is probably something that you should take note of for catheterization, that at the external orifice is much more tough. By the time you get back to the bladder, it's not quite as tough. The internal sphincter, as I said, is involuntary smooth muscle. It normally is closed. You contract it to open, so it stays closed with no expenditure of energy. The external is voluntary skeletal muscle, and you contract it to close it. So you do expend energy when you're trying to hold your pee. The female urethra is fairly short, 3 or 4 centimeters. It's on the anterior vaginal wall, right? And its opening is anterior to the vaginal opening, but it's posterior to the clitoris. It's in the vaginal vestibule that this is here. But it's only inch and a half long, 3 or 4 centimeters. The bladder is sitting very close to it. It's one of the reasons that women, especially as they age, have a loss of, they can become incontinent, especially stress incontinent, because there's not a lot of tube there to contract against. The male urethra is much longer. It runs the whole length of the penis, and actually, because of the prostate, it runs through the prostate as well. So the male urethra serves 2 different systems. The female urethra is only the urinary system, but the male urethra serves both the reproductive and the urinary system. So it's the same tube that passes urine, passes semen. Because of the organs that it passes through, it has 3 named regions. You notice 3 named regions. The part that goes through the prostate is called the prostatic urethra. The part that passes through the pelvic floor, the muscular pelvic floor, which is the same basically as the entire female urethra, is called the membranous urethra. And then the part that passes through the penis passes through a part of the penis called the corpus spongiosum, so therefore it's called the spongy urethra. Sometimes it's called the penile urethra, but strictly speaking the name should be the spongy urethra. So it looks like this. So the trigone is here, anterior corner of the trigone is the internal urethral orifice with the internal urethral sphincter. The prostatic urethra passes through the prostate gland. The pelvic floor is here, so this makes it the membranous urethra, is just the thickness of those muscles, and then running up the whole corpus spongiosum to the tip of the penis is the spongy urethra. There are some glands that we will talk about in the male reproductive system that enter into the urethra here in the prostatic urethra and here in at the base of the spongy urethra in things called the crus. So these two little glands and this gland contribute to reproductive success. This part of the spongy urethra is actually called the bulb. This is called the crus here. So, in both sexes, when you want to pee, we call it micturition. What happens is the detrusor muscle contracts, autonomic nervous system makes that happen, and then the internal urethral sphincter opens, again by the autonomic nervous system, and you feel this urge to pee. Normally at this point we contract the external urethral sphincter voluntarily, and we hold our pee until it's time to go. When you get to the bush or the gas station or wherever you're going to pee, then you relax the external sphincter using the somatic nervous system, the voluntary nervous system, and you start to urinate. The detrusor muscle contracting is what provides the pressure for urinating. It is reflexive at first. It's basically the bladder distends, stretch receptors make the detrusor muscle contract in a nerve reflex. Then you open the external sphincter and you relax and open the external sphincter, and peeing happens. It's a reflex thing. We control it from the brainstem, and we're not going to worry about this. It's the pons that does it, and it can be overridden. The last part of it, the relaxing of the external sphincter, can be overridden by somatic voluntary control at this point. So it inhibits you from peeing. You can hold your pee, where little kids